Good evening, everyone. This is Dr. Adiba Nizam, and welcome to another episode of Conceptual Surgery. Today, we are discussing sentinel lymph node biopsy. In this session today, we don't just learn how to perform sentinel lymph node biopsy. We learn how to answer surgical questions like a postgraduate topper. Today, we are diving into a very important topic, sentinel lymph node biopsy. Whether you're preparing for MS or DNB exams, this is one of those questions that checks your understanding of anatomy, technique, and surgical decision making all in one. So, in this session, we'll break it down, cut to point way, starting with the definition, then covering indications, surgical anatomy, operative steps, complications, contraindications, and finally, the recent trials and updates you need to know to write a high yield answer. So, let's get started. So, why do you need a systematic approach to answering questions on operative surgery? It tells the examiners, hey, I know my stuff, I know how to think like a surgeon, and here's why being systematic really matters. It maximizes your scoring potential. Even if you don't remember everything, a good structure helps you to include all the key headings so you don't leave scoring areas like complications or contraindications. Examiners aren't just looking for memory dumps, they're looking for candidates who can organize thoughts logically like they would in a real OT case. It helps you save time under pressure when your mind's racing in the examination hall. Having a fixed answer format is like a memory muscle. You don't have to overthink the layout, you just fill in the content, and it helps cover breadth and depth. You don't go off tangents, you hit all the key points without missing the forest for the trees. It looks professional, and a neat and a logical answer looks better, simple as that. Examiners are human, and clarity is always appreciated. So even if you're writing about something as complex as sentinel lymph node biopsy, if you break it down into clear headings, your answer immediately feels more confident, focused, and exam worthy. In short, think like a surgeon, write like a teacher, and score like a topper. We will divide answering an operative surgery question under the following headings. It would include introduction, indications, the relevant surgical anatomy, the operative steps, complications, contraindications. This outline can also be used for other procedures that you're writing about, and you just need to add in a few more headings or subtract depending on the question that you're attempting. So let's get into it, and we will start with what is sentinel lymph node biopsy. As we know, sentinel lymph node biopsy involves identifying and biopsying the first draining lymph node or the sentinel node to assess for the spread of cancer. I'd like for you to note here that by a sentinel node, we mean that there may be multiple nodes. It does not simply imply that it is a single node. They may be multiple also. We are referring to the first group of draining lymph nodes. It's a group, not necessarily a single lymph node. So, a sentinel lymph node would be defined as the first lymph node or the group of lymph nodes that directly receive lymphatic drainage from the primary tumor site. Because of this position, they are the most likely initial location for metastatic cancer cells to spread via the lymphatics. This term sentinel is derived from the concept of a guard or lookout, signifying that these nodes serve as an early indicator for the spread of cancer. It acts as a biological filter for tumor cells draining the primary lesion. A negative sentinel node suggests a high probability that the remaining nodal regions which are downstream from this sentinel node would be free of metastasis. Thus, it would spare the patient from a more extensive lymph node dissection. However, if a sentinel lymph node comes out to be positive, it may indicate the need for a further treatment, further nodal clearance, depending on the type of the tumor and the current guidelines. Then, once we have taken out these sentinel lymph nodes, we would be examining them by chemistry to detect the micro and macro metastasis, and it helps us to accurately stage the cancer and prevent surgical morbidity which would be associated when the patient undergoes a direct axillary lymph node dissection without having undergone a sentinel lymph node biopsy prior. So sentinel lymph node biopsy prevents an axillary lymph node dissection where it is not needed, and thus prevents the complications associated with axillary lymph node dissection, mainly lymphedema. To remember, you can think of the sentinel lymph node as the security checkpoint of the lymphatic system. If the cancer cells try to travel, this is where they would get caught first. As you can see in the diagram, the valves in the lymph node allow flow in only one direction. if this lymph node, if the sentinel lymph node is negative, I'm reiterating, if the sentinel lymph node is negative, it is highly unlikely that the lymph nodes downstream from the sentinel node would be positive for cancer. It is very unlikely, and thus the patient can avoid the morbidity of a complete lymph nodal dissection. So we have briefly introduced our topic, which is sentinel lymph node biopsy. We have defined what a sentinel lymph node is and what is the procedure entail. Now we are going to go on and cover what are the indications of sentinel lymph node biopsy. As we very well know, the most common cancer for which sentinel lymph node biopsy is being used is breast cancer. Most of you would have seen sentinel lymph node biopsy being done for a case of breast cancer. Then it also has an established role in melanoma, then in penile cancer and endometrial cancer. Further, sentinel lymph node biopsy has an evolving role. It is being studied for a variety of cancers, which includes multiple head and neck cancers, including the oral cavity, the thyroid, esophagus, stomach, colon, cervix, and the vulva. The role of sentinel lymph node biopsy is not yet established for these cancers, but it is continuously under study and may very well be established soon in the future. Now, we are going to be focusing this discussion on the sentinel lymph node biopsy in breast cancer, because when you are asked in your exam, that would be the most commonly asked question on sentinel lymph node biopsy. If the examiner decides to ask you about sentinel lymph node biopsy in some other cancer, for example, let's say they are asking you the role of sentinel lymph node biopsy in colorectal cancer as a question under recent advances, even if you do not know how sentinel lymph node biopsy is performed for colorectal cancer, you can always write about what the procedure of sentinel lymph node biopsy entails, what is the sentinel lymph node, what is the lymphatic drainage of the colon, then go on to describe what you understand of the procedure. The complications and the contraindications would more or less remain same. So following a structured approach would help you answer this question for any other cancer. Here we are discussing it in relation to breast cancer. So let's move ahead. When we are discussing it in relation to breast cancer, it is very important that we first discuss the surgical anatomy of the breast, especially of the lymphatic drainage of the breast. We know that in the breast, the lymphatic drainage flows in two directions. Medially, it goes to the internal mammary lymph nodes, and laterally, they drain into the axillary lymph nodes. The axillary lymph nodes have the majority of the lymphatic drainage from the breast, approximating to 75%, whereas the internal mammary lymph nodes drain about 25% of the breast tissue, mainly the inner and the medial aspects of the breast. Now, the axillary group of lymph nodes, which are draining 75% of the lymph from the breast, are further divided into 5 groups. These are approximately 40 to 50 lymph nodes, which are divided under the 5 groups as follows. These are the anterior, the posterior, the lateral, the central, and the apical groups. We are going to see in detail what are the anatomical landmarks where these lymph nodes would lie. So, the anterior or the pectoral group of lymph nodes, these are a group of 3 to 5 nodes, and these are located along the lower border of the pectoralis minor and the lateral thoracic vessels. When you are palpating for these lymph nodes, you would be palpating along the anterior axillary fold for the anterior or the pectoral group of lymph nodes. Then we move on to the posterior or the subscapular group of lymph nodes. These are 6 to 7 lymph nodes and are located along the lateral border of the scapula and the subscapular vessels. And when you're palpating them, you will palpate along the posterior border, the posterior axillary fold for these lymph nodes. Then we have the lateral axillary lymph nodes, also called the humeral lymph nodes. These again are 4 to 6 nodes and are located along the axillary vein. You palpate them against the humeral head in the axilla or on the lateral aspect. Then we have the central group of lymph nodes. These are deep and they lie posterior to the pectoralis minor muscle in the fat of the axilla. These again are 3 to 4 lymph nodes. Then we have the apical group of lymph nodes, to which all of these lymph nodes eventually drain. These are 6 to 12 in number. They lie superior and posterior to the pectoralis minor muscle, and this group also includes the supraclavicular group of lymph nodes. We further know that the axillary lymph nodes are divided into three levels by the pectoralis,